Good morning, everyone. This is TransConnect 22nd January 2024. I am Dr. Mohit Chaudhary, Senior Consultant here, and I'll be talking about therapeutic plasma exchange with secondary plasma device and our experience in solid organ transplants. So plasma exchange, we all know, is the basic rationale is the removal and retention of plasma with return of cellular components to the patient along with the physiological fluid. Now, this physiological fluid, we start with the saline and then it has to be replaced with the colloid and the crystalloid. So, basic differences when you give colloid and when you give crystalloid. So, depending upon the disease modality and the pathology that you are going to cater to by the plasma exchange, is we resort to albumin versus FFP. So most of the, unless proved otherwise, it is generally the albumin that we use, but many a times in special conditions like TTP or when there is diffuse alveolar hemorrhage, we give FFP. Of course, you need to see the ASFA guidelines. I'll be talking about ASFA guidelines, just touching briefly upon them, and then it also gives you which kind of replacement fluid you should, provide the patient with. So the effectiveness of plasma exchange is related to the volume of plasma removed and the concentration of pathological substance to be in the blood. It is recommended that approximately 1 to 1.5 plasma volumes be exchanged per procedure. And yes, we have a lot of terms associated with plasma exchange, like PLEX. Many a times we call it PLEX. It is also called as patient plasmapheresis, TPE, plasma exchange. All of this signify the same thing, that is therapeutic plasma exchange. So how do we calculate the plasma volume? So to do 1.1 to 1.5 plasma volume exchange, you need to know what is the plasma volume of the patient first. So for example, suppose there is a patient who is around say 70 kgs. So his 70 kg male. So his total blood volume is what you need to calculate first. So total blood volume is 70 ml per kg for an adult male and similarly 66 ml per kg for a female. So in this example, if you see that if the total blood volume of a person is 6 liter or 6000 ml, so that is your total blood volume. From that, you will calculate the plasma volume. And how do you calculate that? You need to know the hemoglobin and the hematocrit of the patient. So 1 minus hematocrit into the total blood volume will give you the plasma volume. For example, if your hematocrit is 40, then you multiply it by 100 minus 40, that is 60, or 0.60 into 6000, which will give you 3600 ml. So plasma volume will be 3.6 liter and RBC volume will be 2.4 liter. So plasma volume is the volume that you are going to replace with, or you are going to extract the plasma. So that is the amount of volume that you will be replaced. So one plasma volume for this example will be 3.6 liters. Similarly, you can calculate the 1.5 plasma volume. So now this is a very important concept of intravascular and extravascular distribution because you are going to remove the disease mediator. Now, most, if you see in this compartment, this is the intravascular compartment and this is the extravascular compartment. Now, intravascular compartment is 10 times smaller than the extravascular compartment. And most of the high molecular weight proteins or substances which you need to remove are there in the intravascular compartment. And this is a compartment that you're going to target during the plasma exchange. For example, the IgM stays in the intravascular compartment. The fibrinogen is there in the intravascular compartment. So all of this gets removed when you are actually targeting this compartment. Extravascular compartment you see is almost 10 times the intravascular compartment, and it has some lower molecular weight proteins and antibodies like IgG, IgA, IgD. So all of this is there in the extravascular compartment. So if you do a one plasma volume exchange, you will see that 63% of the disease mediator is removed and only 37% of it is remaining. So one plasma volume exchange removes 63% of the disease mediator. Now what happens if you are in IgM, you don't cross or there is no rebalance. But if you are trying to cater to IgG that stays in the extravascular compartment, it many a times it rebalances, and after around 48 hours, IgG and IgA are back to the almost the same levels after the plasma exchange. That is the concept which even David Ward also explained as to how many plasma volumes are needed for any disease. So if you see if it is the IgM that we are catering to in the plasmapheresis procedure, which is a large molecule and 90% of which stays in the intravascular compartment, you can see only 1 or 1.5 plasma volume exchange is going to remove all the disease mediator. But if it is IgG that you're catering to, obviously one plasma volume is going to initially remove the 60%, but due to rebalance, the IgG is going to come back to the intravascular and there's going to be a rebalance. And that is why you need to do multiple procedure almost to the tune of around 4 to 6 plasma exchange sessions. So what is the ideal plasma volume and which will remove? So many a time we have been asked this question as to why don't we do 2 volumes or 3 volumes or 4 volumes? So obviously there is a rationale behind it. So when you remove one plasma volume, obviously it is 63%. When you remove 1.5 volume, it is around 72 to 78%. And when you do two plasma volumes, 86% of the disease mediator is removed. Now, this part of 1 to 1.5 plasma volume is actually the recommended one. Why? Because of the benefit ratio. So what you need to see benefit is to harm ratio, and that you need to see why. Because many a times when you are doing the plasma exchange, it is very non-selective, and a lot of physiological components which are there in the intravascular compartment may be removed along with the disease mediator, most important of which is fibrinogen. You can see that in fibrinogen, which resides in the intravascular compartment, does not come back to the normal levels even after the plasma exchange after 72 hours. So when you are doing plasma exchange, especially multiple sessions, one after another, fibrinogen depletes and that may lead to some bleeding tendencies. So you need to be careful of how much you are going to do. Obviously, if you have 76 to 78% of uh, disease mediator already removed in 1.5 plasma volume, you don't want to go higher than that because then unnecessarily there will be a cost involved, the replacement fluid will be more, and obviously there is chance of bleeding. So small versus large volume, 1 to 1.5 is considered the standard of care. One plasma volume less than one plasma volume is not enough disease mediator is removed and it is not very therapeutically effective. But one greater than 1.5, it requires considerably more time, more replacement, and only marginal benefit. So best is to go for 1 to 1.5 plasma volume. Coming to the fluid balance and how do we maintain it? So most of the procedure, if you see, so when you talk about fluid balance, it can be isovolumic, that is 100%, like fluid returned is to fluid removed, and hypovolemic when it is less than 100%. So more often than not, you will have 100% return fluid that you are going to give. So whatever you are, suppose you are removing 1 liter of plasma, you replace it with 1 liter. But many a times when the patient has a volume overload, you may even go for a negative balance, and that can be like an 80% replacement when you're removing 100% but replacing it with 80%. Hypervolemic, I have never come across. This is when you are removing less and returning more. This seldom happens, and most of the time it will be either isovolumic or hypovolemic fluid balance. Coming to replacement fluids, yes, that is a thing that we should all know what kind of replacement fluid you are going to replace the when you are doing the plasma exchange. So it can be either colloid or crystalloids. So most often not, we start with 5% albumin whenever it is the procedure, and 9 on 10 times you would see that that is the replacement fluid that we recommend. Now, why we recommend that is because albumin itself, it helps in the colloid osmotic pressure. So that is one advantage of this. And second, if you compare it with the citrate content in FFP and cryoprecipitate, which are used as a replacement fluid, it is quite high as compared to 5% albumin that contains small amount. So obviously it can lead to citrate toxicity. And that is why more often than not, there are only special indications in which you need to have FFP or cryoprecipitate. One of them is TTP. We all know we use FFP and cryo in that. Another is when you have a diffuse alveolar hemorrhage, or when you are in a liver, you are doing it in a liver patient when you want to replace the coagulation factor. So you can even go for a 50% albumin and a 50% FFP. Coming to ASPA categories, these are very, very important for us, and in the sense that all the blood bankers, if you see, always have this. It's like a Bible for the transfusion medicine people who are using uh, this apheresis procedure, and it is a ready reckoner because it lists all the diseases according to which you can do a plasma exchange. They are in an alphabetical order, so whatever disease you are catering to, you can just see. It will tell you about the category. So it has divided it into four categories as to how effective the plasma exchange is going to be. I'm going to talk about that. Also, if you see, it will tell you what is the frequency of plasma exchange you're going to do, what is the rationale behind it, what is the exchange or the return fluid that or the replacement fluid that you're going to give. it will tell you about the frequency of the procedure as well. So it is a very good ready reckoner, and it updates itself uh, every now and then, every 3 years or so. And this is the ninth edition or the latest edition of the ASPA guideline, that is the American Society for Apheresis guideline, and it is published in the JCA, or the Journal of Clinical Apheresis. Coming to the category definition, according to the ASPA, it is divided into four categories, like I said, category 1, 2, 3, 4. So, category 1 is the first line therapy, where the plasma exchange is considered as a first line therapy. Second is the second line therapy, in which it is a category 2. The third is the optimal role of apheresis therapy is not established yet. And fourth, or category 4, is when it is ineffective or harmful and we should not, go for plasma exchange. So this you can always follow as to which disease is in which category, and accordingly you can plan your plasma exchanges. A very important concept of centrifugation plasma exchange versus membranous plasma exchange. Centrifugation plasma exchange is what we do on a apheresis machine that we have in blood bank, and membranous plasma exchange is what we have for dialysis machine. So they have a membrane through which the plasma exchange is done. So basic principle is whole blood in a filtration membrane process. Whole blood along with the anticoagulant goes through the hollow fiber of this plasma filter. And what it does is, based on the difference in the particle size, it separates plasma from the cellular component. So basically the pore size of the filter is what it matters. And it's like a sieve from which the smaller particles are going to move out and the higher molecular weight particles are going to stay back. Whereas in centrifugation, it is the specific gravity and the centrifugation force that is going to be there, and that will separate the various components based on the specific gravity of the components. So these are the two methods that are available. This is done through a dialysis machine, and this is through the apheresis machine that we have in the transfusion medicine. Now, there have been various papers that have compared the centrifugation plasma exchange versus membranous plasma exchange, and hands down, centrifugation plasma exchange is better. And why? Because the most important aspect is the time for the actual procedure, right from the setup time to the prime time to the procedure time and to time to exchange the 1 liter of plasma. So all of this combined together, if you compare with the membranous plasma exchange that we do, it is actually two-thirds the time as compared to the membranous plasma exchange. So what it does is, your time is saved, your manas are saved. Obviously, when your time is saved, your return fluid is less. So the procedure takes lesser time. The efficiency is better. If you see, the plasma removal efficiency is 80 to 93% in the apheresis machine, whereas if you go for a membrane or a dialysis machine, it is 27 to 53. The inlet blood flow is another advantage. You can go as low as 5, especially in pediatric patient, or when you're combining it with a CRRT. So that is when it is very handy, and this machine can go to these low levels. But you require a higher level of pressure or the inlet blood flow rate, and that is around 50 to 100 in the membrane. So this also means that you should have a central venous catheter, whereas in uh, centrifugation plasma exchange, you can even do with the peripheral lines at times. Of course, the anticoagulant that you use here is whereas whereas if you see in the membranous plasma exchange, it is heparin. So obviously, heparin has its own problems. Heparin induced thrombocytopenia, we have all heard of it. Of course, it does not happen very often, but it has got its own implications. Now, coming to non-selective versus selective extraction of plasma constituents, we all know that 63% of the disease mediator is removed in one plasma volume exchange when we perform that. But then also with it, a lot of normal stuff or the normal physiological ingredients are also removed. If you see, during one plasma volume exchange, 150 gram of plasma protein is removed. Now, this 150 gram means that 110 gram of albumin and 40 gram of globulins and other proteins is removed. So majority of these plasma components are involved in the physiological functions. So when it goes, obviously your physiological function suffers, and this replacement fluid that we do or give, it does not have all the normal plasma constituents. So everything has a a side effect. If you see, if you're doing a plasma exchange, obviously some normal stuff is also removed. So all of this is replenished. Our body is such that it is replenished very fast, but like 4 hours for factor 8 and factor 9, and 24 hours for almost all coagulation factors are recovered. But only problem is the fibrinogen, which takes around 72 hours to come to that, to also 66% of its normal value. So obviously you have to monitor when you're doing a lot of plasma exchanges. The key is that you monitor for fibrinogen. Many a times your fibrinogen level may be too low. You can supplement it with a cryoprecipitate, which is a rich source of fibrinogen. So you need to keep that in mind. Otherwise, there can be some kind of a bleeding tendency because of the low fibrinogen level. Now coming to selective extraction of plasma exchange. So we have talked about non-selective and everything is removed. Now there are some kind of filters available which are extremely selective to minimally selective for some kind of a plasma exchange procedure. So you need to know which kind of a filter you can use. There are semi-selective filters, there's highly selective, and there is minimally selective. So what is the advantage of plasma exchange with secondary plasma device? This is a device that we attach like a filter over the conventional plasma exchange. So what happens is there is generally we do not require replacement fluid. The patient treated plasma serves as a replacement fluid. So basically all the plasma goes through this filter. I'll tell you about the circuit, and then the same plasma goes back to the patient. So it's not like you are supplementing plasma from outside. Similarly, so what is the rationale for selective immunoadsorption column? It is basically used for ABO incompatible transplants where you have to overcome this ABO titer. So you have to reduce the titers. So this selective immunoadsorption column have this carbohydrate antigens that are coated to them, and it's going to absorb those antibodies. So it is very selective. It reduces the plasma titers, and that's how it functions. Contrary to that, there is a cascade plasmapheresis or EVA flux, as the company says. Now, this is highly useful. People have tried it in ABO incompatible transplants as well because it's semi-selective. It's going to remove the ABO titers. But what it actually does also is, from our experience, I feel it is very handy in HLA incompatible patients. So in HLA incompatible patients, it is very helpful to reduce the HLA antibody titers. And we have had many cases in which we have tried EVA flux or cascade plasmapheresis, and it has been very helpful. So what is the basic principle? Basic principle is it is a combination of uh, two principles. Basically, what happens is when the blood goes from the patient, you have a centrifugation mechanism in which the cellular and the plasma part is moved, in the sense that when the high molecular weight substance and low molecular weight substance, the blood cells, all of this is removed, and the membrane plasma separator is here. So when you have this, first is centrifugation. So obviously you separate it according to the centrifugation density, and then it passes through the filter in which you can see the high molecular weight substances are removed from this, and the low molecular weight substances along with the plasma sieves through, and that is returned back to the patient. So both the mechanisms are, you know, taken care here. So whole blood first is separated into blood cell and plasma using the centrifugal cell separator. The plasma sieve through the plasma fractionator, wherein the high molecular weight substance which are desired to be removed are, and low molecular weight substances are segregated. Now this substances, high molecular weight substances are cleared in a waste bag, and low molecular weight substances are returned back to the patient. The basic principle of cascade. Why it is called cascade? You can see that there are one after another, or a compound effect from one after another. So it's like a cascade or a waterfall. So that's why it is called a cascade plasmapheresis. So these are various indication of EVA flux. We have done it in a ABO incompatible transplant. We have done it in HLA incompatible transplant to reduce the HLA antibodies, and we have found that cascade plasmapheresis or cascade filtration plasmapheresis is much effective in HLA incompatible transplants. So analysis of use of EVA flux in HLA incompatible renal transplant. Our experience, if you see, we have done it for 18 patients, 6 prospective renal transplant with ABO compatible recipients. So in HLA incompatible patients, 2 plasma volumes were processed at all times, and treated plasma was used as a replacement fluid. So you can see in these cases, I'm not going through the the data, but what I'm very certain is that these plasma volumes, when we do 2 plasma volume, when we do an exchange with an apheresis secondary plasma device, we have got very good results. One of the other secondary plasma device is a selective extracorporeal immunoadsorber, like Vitrozorb or Glycosorb. So what it does is the patient blood goes into this plasma separation or a filtration, and it goes from this column. So this column has this carbohydrate antigens that are coated to them, and obviously it is going to reduce the ABO titers, and then the rest of the thing is returned back to the patient. So the column type is 70 ml. It requires some priming. The dimensions are mentioned here, and what it has done is that the blood group barrier has been eliminated. So we can take it from A to B, B to A, or AB to B, AB to A. So all of this is possible in multiple. So because of the donor pool that is getting extinct day after another, so we have this provision when we don't have a suitable donor who is group matched, we can go for a selective immunoadsorption column like Vitrozole. So the rationale is that ABO secorum or the Vitrozole employs the synthetic carbohydrate antigen immobilized on porous polymer beads to exclusively reduce the number of ABO antibodies. The specific removal of antibodies by secorum ABO prohibits several side effects that are compared to other pre-treatment methods like plasma exchange. So it is a very selective method and it's been very helpful for us. What we have done is we have done it in 2 cases of renal transplant and 2 cases of liver transplant, and all the 4 cases we have managed get the titers from as high as 512 to 56 all the way low to 1 is to 8 and 1 is to 4. So it has been very helpful for us, and I think it is a procedure that people have a perception that the filter is a little costly, but if you see the average length of stay, the patient anxiety, and the kind of resources that are required, it is really helpful for the avian compatible transplants. So this has been very helpful for us. Now, this is a paper that we had on therapeutic immunoadsorption and conventional plasma exchange in incompatible renal transplant. So we actually went and saw around 1,600 patients in which 49 of them were exchanged. There were 280 in plasma exchanges, and the average number was 5.7. And we compared the efficacy of and the overall expenditure of the immunoadsorption column with the conventional plasma exchange, and found that when we do a therapeutic immunoadsorption column, it is much, much better in the sense of even the cost and also the effectiveness of the filter itself. This was one we did in liver transplant. We did 3 cases, and the number of changes were quite less, and every time we achieved the target of less than 1 is to 16. So take home message, the therapeutic plasma exchange is here to say we have the ASPA guidelines, which are a ready reckoner. You always need to follow them. They are updated. In fact, when you have a special case or suppose you have a category 3 disease modality which you want to treat with plasma exchange, you should always try to publish it. That is how the guidelines are developed. When you send the papers and then your thing is known. So therapeutic plasma exchange with secondary plasma device is a very effective tool. We have had experience with both cascade filtration and selective immunoabsorption column, and both are found to be cost effective, and this helps in lowering the titers. And there are many newer indications that are coming up with these procedures. The idea is to start doing it, and once you start doing it, you will be knowing that what are the pros and cons of it and where you can employ it. Thank you so much. If there is any query regarding this, I'll be happy to answer. Thank you.